Welcome everybody for the Pan-American Society International Telegram Rounds, year 12. I would like to introduce the presenter today. He's an old friend, one of the first physicians and surgeons from Brazil to participate, Dr. Francisco Collet Silva. Dr. Collet is a professor of surgery at Faculdade de Medicina da Universidade de São Paulo Medical School. He's also the chair of the telemedicine committee for the Pan American Trauma Society. Dr. Collet always gives us good case, and he's going to be talking today about transfixing abdominal gunshot wounds. We have many people participating from around the Americas here today. I would like to say you have two important guests from Brazil today also. Not only Dr. Fraga, Dr. Collet, other friends, but have also the former president of the Brazilian College of Surgeons, Dr. Savino Gasparini. And we have also the new president of SBITE participating today from his hospital, Dr. Mauricio Godinho. Welcome everybody. And both of you, Dr. Godinho and Dr. Gasparini, if you want to participate to any comments, please feel welcome. Dr. Collet, thank you for presenting today. Happy New Year. Looking forward for a great case.
Well, I hope you all enjoy the case. Thank you for the presentation, Antonio. It's nice to be here. The case, I think, is very interesting. I want to know some points in this case for that's a very interesting case. Okay, here, okay. Here is a 30-year-old man. He's a policeman, okay? He comes for us by abdominal transfixing gunshot wound. So this is information that you receive by the our transfer procedures. In the pre-hospital, sometimes they told us what has happened and share information to us. That's very important to treat the patient and to show the adequate equipment you need to do to treat this patient. Sometimes in most parts of our country here, my country, you don't have information about the patients that the pre-hospital will get to the emergency room. Sometimes you receive the patient with no information. In this case, you have received the information. The machine of this patient is abdominal transfixing gunshot wound. The injury, the entrance wound was on the right flank at hemiaxillary line. Exit wound on the left flank at anterior axillary line. Airway was clear, breath respiratory sounds present bilaterally, oxygen saturation is 98%, circulation, blood pressure is not informed, but he has a cardiac rate around 140 BPM. Glasgow Coma score is 14, and abdominal injuries that I told you. For transportation, you go to show you our transportation, helicopter transportation here in São Paulo. The patient was intubated for transportation and put in mechanical ventilation. A venous access was put 1,000 milliliters of saline, transamine, 2 grams was sprayed in the pre-hospital, and bandage of the abdominal wound. The helicopter transportation will be more than 20 minutes. I want to know, all the people, if you receive this information, you go to put this patient on the bay to evaluation the patient, or you can take these patients directly to the OR, to surgery. What do you think about to prepare in this situation? That's the first question.
Thank you, Dr. Collet. Dr. Fraga, your comments, please.
Hi, Dr. Collet. Probably another good case. It depends on what you have in your hospital, the protocol you have in your hospital. I know some hospitals in the United States, not in Brazil, maybe in Brazil only a few hospitals, they have the OR resuscitation and the patient go direct to the OR situation like this one. because this patient is on shock, is a penetrant injury, and this patient needs a surgical treatment. In your experience here in Campinas, usually the patient arrive at the emergency department. Usually you try to organize the team, communicate the OR, to prepare the room, the blood bank, to prepare blood, but usually go direct to the emergency department, a quick evaluation of the patient, ABC at the scene. You need to have collective blood of the patient for cross-match and have the definition about the transfusion. Probably you activate the massive transfusion protocol. I think it's necessary for this case. And the fast exam is important in this case, mainly because of the hurt. You need to look at the pericardial effusion in this patient. Maybe this patient has a tamponade. So in your experience, go to the emergency department, emergency room, but prepare the operative room. I think it will be the next step for this patient. Thank you.
Thank you, Dr. Fraga. Dr. Ochman, Boston.
Well, here it will depends on what the helicopter team requests. We have a well-developed protocol for these cases, but the requests usually come from the crew and the helicopter that say, okay, we have a patient who's unstable, we've seen this patient needs to go straight to the operating room. That when that protocol gets activated, the patient gets transported from the helipad to the operating room, the blood bank, everybody is activated in advance, and the blood bank will send the massive transfusion package that consists in 10 units of PRBCs, 10 of FFP, and 2 packs of platelets. If not, this patient go to the OR where we have a refrigerator with 4 units of PRBCs, and we activate the massive transfusion protocol from there. So it all depends on what we hear from the crew on the ground. We never, I think that in all these years, only once we overruled the crew that requested the transfer to the OR, and it was for something else. But otherwise, that's the way that we made the decision here. Thanks.
Thank you, Doctor. Dr. Lenin from Ryder.
So yeah, this is very interesting. I mean, debate we have here every once in a while too. There's actually a few abstracts that just came out at the last Eastern Trauma meeting, like last month about this. But we don't have our place set up to go emergently to the operating room either. Some of the things we do now, our OR is only like 10 seconds away. It's like 30 feet down the hall, but you know, we've seen sometimes the jobs that get done in one area, if the people aren't used to it, can cause some confusion. So we usually just stop for like a minute in the ER, get some blood for, you know, type in cross, make a quick checks of everything, and then move to the operating room in a case like this. But, you know, it all depends on how your system's set up to deal with it, I think. But
Thank you.
Obviously, I think this guy's going to go to the operating room pretty quickly.
Thank you, Dr. Lenin. Dr. Kasim, your comments?
Good morning. So it all depends on what type of protocol that you have in your hospital, and also the logistics that play a part in your own environment. In some hospital, you have this set up properly. For example, in Baltimore and San Diego, they can go straight to the operating room on a case like this if they can trust the transferring doctor or the medical crew which is transporting the patient, that their clinical acumen is correct. in taking the patient direct to the hospital. By and large, in my opinion, it is much better to evaluate the patient in the trauma bay, even if it takes only 1 minute, like my previous surgeon has said. I think that gives you a little bit of time to think about it, formulate what you want to do, and like he said, get the blood cross matched and get all the logistic cleared. But it has to be done expeditiously, and then you can move on from there to what direction that you want to go. Either play, um, stay and play, or go straight to the operating room. So it all depends on how the logistics is going to work out in your own institution. Thank you.
Thank you, Dr. Kasim. Dr. Antrak, your comment?
Yeah, so I agree pretty much with all the comments that everyone just made. And in this case, pulse of 140 is very concerning, but the Glasgow Coma scale of 14 and no report of the blood pressure, whether that means that they were unable to obtain a blood pressure or whatever, but Glasgow Coma scale of 14 indicates that, the patient is at least awake, and really still some not clear about exactly where the wound is. It goes from side to side, but we don't know the level of the abdomen. And I suppose it's possible that it could have been a very anterior wound and went through some loops of bowel, or based on the information we have. But in our hospital here, the trauma bay is right on the way between the entrance to the hospital and the operating room, and they're very close. And the patient would probably stop in our ER. We'd get him all set for the OR very quickly, see exactly what's going on, and then proceed to the operating room expeditiously.
Thank you, Dr. Antrak. Dr. Nedelkoveciu, your comments, please.
Hi. So here at Jefferson, we have the operating room, the EDOR, we call it. It's right across from the trauma bay. I think probably with this case and with him being tachycardic, I would probably err on just meeting him straight in the EDOR, where I could do everything that I would be able to do in trauma bay. And if I decide that he needs imaging, then we can go from there with imaging. But I'm suspicious that this patient is definitely going to need intervention. I would prepare over there. I'll just get an X-ray, see how things look like. If he needs a chest tube or not, I would start with some whole blood. We have some blood in the fridge over there, and then activate MTP. With regards to the fast, I would just look at the pericardium quickly, see if there's any problems with that. Just the way it's kind of described, this could be kind of going across the lower thorax on each side, or upper abdomen. And then for access, I would like to have something placed above the subclavian and give you some antibiotics, OG tube and Foley and send labs. Thank you.
Thank you, Doctor. If anyone else has a comment, please raise your hand, and you will be invited to comment. If not,
I have a question, Valera, from Campinas. A question. Our friends from Europe, they have the European trauma course. They work with the concept of the trauma team, the teamwork. And in some countries in Europe, usually the anesthetists go to the emergency room to join the team to resuscitate the patients. What do you think about this experience? Not go direct to the OR, but call the anesthetist and the team to go to the emergency department and start to resuscitate the patient. Sometimes you need a ED resuscitative thoracotomy. What's your experience in the United States with this team approach?
Hey, Fraga, here in Miami, every call that we have at the trauma bay, the anesthesiology team is with us, and they're part of the team, and they do the intubation usually, and we run everything else. But I know some places is different, but at least here at Ryder you have that I see I have some other people here. Maybe Dr. Elizabeth from Africa. If you have any comment, Dr. Sarah Ashley, that now she was in my analysis in Jacksonville. And Dr. Cassim, let's just quickly go through all the room to some comments. Elizabeth, Betty, how are you?
Hi. Yeah, can you hear me okay? I am having some internet issues here in Malawi. But yeah, I mean, I agree. If you have the ability to just do a quick evaluation in like the trauma recess bay, like you have there in Miami, that can give you some more information. Obviously, if they come in and the vital signs are like peri-morbid, you might go straight to the OR, but it's always good to try to get as much information as you can, even if it's just another set of vitals, a quick fast, maybe an X-ray, something like that. It's hard to be in the OR and then realize you want some information that you can't get there. So.
Sarah, comments? Dr. Ashley? Dr. Cassim?
In answer to Dr. Fraga's question, may I tell you a little story? This is the accident that occurred in the tunnel when Princess Diana was injured. A team of surgeons were sent to the injury site, and they stayed and played. And of course, you and I know what happened. And what Princess Diana died of was a very innocuous injury when you think about it. She had a tear in the pulmonary vein. She did not have any arterial bleed. It was a venous bleed. And I'm pretty sure that if they would have arrived in Miami or Dr. Fraga's institution or some other institution, she could have been saved. And lessons learned from that is stay and play is not a very good idea in a trauma situation. I think the quicker pick and run and get to the destination you want to get there is a much better idea. Does that answer your question, Dr. Fraga?
I'd like to ask Lanin. Dr. Lanin, all these patients come to the trauma bay first, but how long you keep this patient in the trauma bay before sending him to the operating room?
I mean, if it looks like what he's describing, I mean, he rolls in, he gets an ankle bracelet with an ID and a typing cross goes off, and then he rolls back out. So we wouldn't even hook up the leads. We'd feel for blood pressure. We're not, there's an anesthesiologist in there with us, but the rest of the team is getting the OR ready. So it's really, pretty quick. Maybe he'll roll in and we'll find out maybe it's not what we thought. But it gives us a minute to kind of take a look and make an assessment.
Yeah. Dr. Parreira, how would this be in Santa Casa de São Paulo?
Okay, can you hear me?
Yes.
Well, expeditiously to the OR. We don't have the anesthesiologist back down in the ER, so we go to the OR as soon as possible. The controlling of hemorrhage is the utmost point here. We should not delay or postpone it. Even if we end up in a negative laparotomy, it's important to really wait what the time is for this patient. If you have a patient bleeding and you stop in somewhere, well, you decrease the chances of a good result. So there to the OR. But I know Dr. Collet. If he puts here to discussion, there is to be something here that he's expecting us to discuss. I'm not sure we get there, Dr. Collet.
Back to you, Francisco. Yeah, yes.
Just a comment to Dr. Cassim. I think the situation by Prince Diana is a little different because they played as the scene, not in the hospital, at the emergency department. They stayed so long at the scene. The pre-hospital in France is totally different than the system you have in the United States. And she stayed a long time at the scene, maybe at the emergency department. It takes so long to go to the OR. But what I have learned with our friends from Portugal, from Spain, they organize a team like you have in Hyde Trauma Center, and maybe in other centers in the United States. The anesthesiologists go to the emergency departments. The team has the contact with the other specialties that sometimes is necessary, and immediately you have more people try to resuscitate the patients and go together to the OR. But I agree, if this patient probably needs to stay a few minutes at the emergency department. And if you have a fast exam positive at the pericardium, the treatment will be different because it's a thoraco-abdominal transition, the gunshot wound. You come from the right to the left. So it's very dangerous, this mechanism of trauma. Just this, thank you.
Antonio, may I continue the presentation because I have some more. Okay, let's go. Let's go. The great problem for me is my emergency room is on level 4 of the hospital. The heliport is on the level on the 11, and the surgery is on the 9. So there is a very big distance from the heliport to the emergency room and the emergency room to the OR. So sometimes it's very important. And one question that I have is I see that the trauma surgeon or the people who are working with the patients may be in the hospital to treat these patients in this case, maybe not distance or in the home, and then be on call. So it's very important to know that. Here, you can see the date, 24 December, 5:40 p.m. You know that's the date? So here is receiving the helicopter. You can see the hospital where you have a helipad and the helicopter arriving. Is that the helicopter that you have to transportation the patients to my hospital? And this the helicopter will transportation any trauma people in the Brazil. Here is the patient in the helipad. He can be dressing on the entrance room and exit room. That's the patient. Okay. On the helipad, the patient has oral trachea intubation. Respiratory rate was 60 EPM. Saturations are 100%. Murmur vesicular present. Blood pressure 10 to 60 centimeters of mercury. Cardiac arrest of 130 BPM. Glasgow coma stories patients intubated, sedated 3. And pupil is isocorgan for region. Entrance room on the right flank, on the MXLR line, exit room on the left flank. I think if I want only one question. If you put these patients to emergency room, what do you want to do? You go to image exam, you go to a laparotomy, or can go to a laparoscopy. Because sometimes when I saw transfixed abdominal, some abdominal injuries, gunshot abdominal injuries, sometimes some people go thinking about put in this situation sometimes to a laparoscopy. So what to do with these patients? You can see here that the transfix, the abdomen is not the transition of thorax transition, is only an abdominal transition, transfix wound, not a thoraco-abdominal transition wound. Okay, so what to do with the patients? You go, so if you put these patients to for the bay, what you think to do with these patients? Go put the bay and go to laparotomy, put the bay and go to CT or ultrasound or X-ray, or if you put you decide you can think about to put in laparoscopy. The patients may become stable at this moment.
Okay, thank you, Dr. Collet. Dr. Antrak, Iraq?
Yes, so this reminds me of,
Sorry,
go ahead.
can you go back to the vitals? Sorry, I got distracted and I didn't see them. My apologies, Dr. Untra, for interrupting you.
No problem.
Go ahead, Dr. Antrak.
Okay, so this reminds me of a patient that presented to us in Sri Lanka that was 96, probably 1997, and with a gunshot wound in the torso. In this case, the entrance wound was in the flank, and then the exit wound was sort of in the groin on the other side. And so, somebody else said, well, you got to really figure out what's going on. It may not be what you thought it was. And that patient was very quickly, so long ago, I don't remember if they stopped in the ER, but it very quickly was in the operating room. And when we got there, the vital signs were fine. And, then you take a look and you have the patient disrobed, and it turned out that the wound was entirely extraperitoneal, and so we just irrigated the wound, and so in this case, the blood pressure is 100, and I'm very concerned, obviously, about the tachycardia. So I think you have time to do a little bit. If in this case, I guess he would be in your OR. I would do a fast exam, confirm whether or not you have bleeding, or if it definitely is intraperitoneal. Then, if it's mostly anterior, he still needs a laparotomy, and I would likely proceed at that point. But unless you're really, it's possible that it could be all extraperitoneal in the abdominal subcutaneous tissues, and that would become obvious on exam. So I think with those stable vital signs are in the OR. Rather than take him out to get a CT, I would try and do some evaluation there and have a very low threshold for doing a laparotomy, even if he has a blood pressure of 100. I think that was your question, right? I think that was your the question you asked. Anyway.
Thank you, Dr. Antrak. Yes, Dr. Lenin.
Well, I mean, there's not much I'm going to do in the recess bay. I guess this could always be two different shots, but based on this, if, we listen to breath sounds and his lungs are up, he's just going for a laparotomy. I mean, even if it's negative, it's negative. With a heart rate of 130 and a blood pressure of 100, and a transabdominal gunshot wound, he's probably gonna go for a laparotomy right away.
Thank you, Dr. Lenin. Dr. Fraga, your comments, please.
Yes, you need to remember this patient received 1 liter of crystalloid. He is still tachycardic. He has now blood pressure. I think to have the best definition, the fast exam is important, just to have idea if you have just a small amount of blood or fluid in the abdomen, or if there's a lot, so you go direct to the OR for laparotomy. So I think the fast exam is very important. And you need to activate the massive transfusion protocol. I think he has criteria because he's still tachycardic. You need to prepare blood for this patient. I don't feel comfortable to think about laparoscopy in this patient because the patient was on shock at the scene. At the emergency department, he's still on shock because he has tachycardic. So I think laparotomy is a safe option, but maybe Dr. Collet will bring more information to help us to have the correct answer. But there's no the correct answer. The correct answer is the physician, the surgeon who is there to take the decision. Sometimes the decision is not easy to do. Just this. Thank you.
Thank you, Dr. Fraga. Dr. Ochman, Boston.
Well, this patient arrived today. So I will do ATLS. I'm on the scene for ATLS. I will obtain a chest and an abdomen X-ray, which doesn't take too much. They're very quick, because this, as Dr. Levine mentioned, this could be 2 gunshot wounds. So I want to see the location of the bullets. Maybe there are 2 gunshot wounds going to the chest instead of transabdominal. Obviously, we know the lecture, the topic of the discussion today. But that's what I will do. I will make sure that I'm not missing any other. There are no 2 bullets there with 2 separate entrances. And after that, I will take this patient to the OR for an exploratory laparotomy. I will not do a laparoscopy on this patient. I think he's in shock. You can attribute the low blood pressure maybe to sedation. I don't know what they are using for sedation. I assume propofol at this time, but that would not explain the tachycardia. So this patient is in shock. I would take him to the OR and I proceed directly with an exploratory laparotomy. Thank you.
Thank you, Dr. Ahmed. Dr. Kasim, Portland.
I think I probably will do 3 things, like Dr. Hoffman mentioned. I'll do a chest X-ray and I'll do an abdominal X-ray, mainly to look at the trajectory and count the number of bullets, if any. The second thing I would do, it's a transabdominal gunshot wound till proven otherwise, maybe 2 bullets, maybe 1 bullet, and it may be retroperitoneal. So I would utilize my clinical acumen. What are the organs that I would be concerned about? I would be concerned about the kidney and the retroperitoneal duodenum and the retroperitoneal organ. So I would probably put a 40 catheter in to see if there is any blood in the urinary tract. And then beyond that, I don't think I would do anything else other than resuscitate the patient and take him to the operating room. Like the visiting professor mentioned, if I get a negative laparotomy, so be it. And I think the probability of me finding something significant is much higher than otherwise in a patient with a blood pressure of 100 and tachycardia of over 130, and he is young. His blood pressure is 100 because he is well compensated. Thank you.
Thank you, Dr. Kasim. Dr. Nedelkovici, your comments?
As I mentioned with my first comments, I think getting a chest X-ray and putting an OG tube would be helpful. If you see blood in the OG tube, then probably went through the stomach, so he needs an operation for that. If the Foley is with blood, then as Dr. Kasim said, then he probably got the retroperitoneum. He doesn't look very fit by the picture, but still, and he's young. A heart rate of 130 is shock until proven otherwise. I would just go ahead and even if I do a mini laparotomy, I would still go with that intervention. Thanks.
Thank you, Doctor. Dr. Martos, would you like to make any comments or call someone else?
Let's keep going, please. Thank you.
Okay, if anyone has a comment again, please raise your hand. Dr. Collet, we will go back to you.
Okay, let's go to what's happened. Here you can see the blood gas in the OR. Is the first blood gas. He is in shock. He's acidotic. XSS mean 5, and the lactate was 37. So I see this patient. I saw the patients in the helipad, and I transferred the patients to the emergency room, to the surgery, direct to the surgery. So here you can see the patient. Here you can see. I know the very important when you have 2 wounds, you can check the patient if there is only wound or only 2 or other wounds in the back. So in these patients, I go to show you. I will stop the movie and ask a question, but here you can see, here is exit room. Here is the entrance room. You can see the exit room, there is a bowel on the exit wound. It's very different, the entrance wound and the exit wound. So you can see it and show what's happened. Here's the patient in the OR. I go to show something. Here is the entrance wound on the back and on the other injuries. So I decided to open the patients. As soon as patients is activate the blood transfusion, you can find in the abdominal about 200 millimeters of blood in the feces. And we start with tamponade. All the quadrants.
Collet, 2 liters of blood? 2 liters?
Yes, yes.
Correct. Okay.
Here you can see, I put pads around the liver. We have to cut the falciform ligament to facilitate to put the pads. If you try to put this, you can increase the injury. Here you can see the pads. Here you can see the injuries. Here is the left, the hepatic colon. Here on the near is the duodenus near. Here you can see blood comes from the mesocolon, the pancreatic area, through the mesocolon. Here you can put pads and compress, and then you go to see what's finding in the abdomen. You can see some injuries of the small bowel. You can see injuries of the small bowel. There is another injury here in the small bowel, tangential injury. And then you can see something very different that I can never see. You can see through the exit wound, herniation of the bowel. The small bowel herniation through the exit wound. This is a very high injuries that maybe come through aspiration the bowel through the exit wound. Here you can see, and decide to start with control the wall, and then I go to ask you, can see here, put the stapler, make another correct the injuries and stop it, and then start to make mobilization of the column on the right column, make a Cattell maneuver to see what's happened on the heteroperitoneal area. The blood from the liver is stopped by the by the dressing, by the pads. And here you can see here some injuries in the near the head of the pancreas. I go to put more to see here. Open them again. There is injury of the right column on the hepatic area, hepatic angle area. I resected or stapled this area. And then here you can see some vessels come from the head of the pancreas near the duodenum. You can see the injuries of the vessels. There is no transfixion the pancreas, but here you can see the injuries of the vessels was tied. There is no duodenal injury in this moment, not see that. And then I go to show the liver. Here you can see the head of the pancreas. The vessels was tied. There is no pancreatic link, no injury of the pancreas. Here's the duodenum, but the vessels, you can see the head of the pancreas. It's a pancreatoduodenal artery injury, and here the liver injuries. Okay, let's go. The question: at the moment you stop the surgery, and then what to do with this patient now? You can reconstruction immediately the surgery. You can stop damage control surgery, reconstruct the ball, not reconstruct the ball, tamponate the liver, try to make something different in the liver, what to do? Antonio, Pippo, Valeria?
Thank you, Dr. Collet. Okay, Dr. Ochman, Boston.
Well, I don't know exactly the interest in the liver. I see here, say segment 5. So the portal vein and the hepatic artery were not affected and the common bile duct. Because with an injury in that area, we'll be very worried about that.
No, there is no artery, no portal vein injury.
If I control the bleeding and I control the spillage, probably I will stop there, leave the abdomen pack, and let the patient recover because this is a significant insult. I will make sure before I leave the OR that I have the liver bleeding control because the patient might need to go to interventional radiology. But otherwise, that's all I will do. The only thing I will do different is I will go from the bleeding first. I don't worry too much about a spillage from the bowel. I will go and control the bleeding first, and after that, I will control the spillage the same way that you did, Dr. Collet, with a stapler and leave it there, and we'll just get out. Thank you.
Thank you, Dr. Ochman. Dr. Fraga, Campinas?
I agree. I think this patient is a candidate for damage control surgery. So control the contamination with staple is a good option. You need to talk with the anesthesiologist. How is the patient situation about the blood transfusion? Because the patient was acidotic on admission, the first blood gas. I think you need to have a very quick surgery. You need to control the bleeding. I'm sure they checked about the portal vein because the trajectory was very close to the pancreas, but no pancreatic injury. Sometimes go maybe splenic artery, you can have injury. They probably did a good inventory of the cavity. So and the liver, if there are a lot of bleeding, you need to do the classic maneuver, Pringle, etc. But probably tamponade the liver will be a good option in these patients. If the bleeding you can control by tamponade the liver, and keep the abdomen open and go with the patient to ICU and come back in 48 hours.
Thank you, Dr. Fraga. Dr. Lenin, your comments?
Man, these are great pictures, by the way. I mean, yeah, I think I would do pretty much what everyone's saying. I mean, if you can control that liver and it's packed off, I would probably get out at this point and resuscitate them before I attempt any reconstruction here. Obviously, we want to make sure nothing else is bleeding, that this didn't hit something so you take a look around and make sure nothing's bleeding. But I think before I would do a reconstruction, I would probably let this patient recover a little bit.
Thank you, Dr. Lenin. Dr. Antrak?
Yes, I agree wholeheartedly with all those comments. I think I had the same thought that Dr. Hochman had about the order, the bowel control and then the bleeding, but it very likely when Dr. Collet had everything packed off, the bleeding was under control, and the patient, the vital signs were okay, and that's why he did it that way. And in this case, with the 20-minute helicopter ride, and then by this time it's probably an hour, 90 minutes after the injury. So you're way ahead here, and it's and I agree, just stopping there and resuscitating the patient, correcting the acidosis, and then come back in a day or two to reestablish continuity of the bowel, and making certain that there's no ongoing bleeding as well.
Thank you, Dr. Antrak. Dr. Kasim?
Well, anytime I open the abdomen, I find 2 liters of blood in there. I always say, holy shit. Immediately my mind goes to only one direction, which is damage control. I need to stop the bleed. I need to get out of the OR as soon as possible with a live patient. So the way Dr. Collet, the master surgeon, has conducted himself is what I would do as well. I would staple off the bowel injuries. I would not reestablish any continuity at this moment. I would try look at that pancreatic injury very, very carefully that I'm not missing anything here because that would be a disaster. And having control whatever was bleeding, probably superficial vessels, and of the pancreatic duodenal injury, having determined there's no hole in the duodenum, I would take the packing off from the liver and look at it, and I would deploy any topical agent such as glue, etc., and to stop the bleed in the liver. And that's where I would be spending most of my time to stop the bleed, pack it if necessary again, and then I would take the patient to warm him up, resuscitate in the ICU, and come back the following day or 48 hours from now to tackle this patient one more time. That's what I would do. Thank you.
Thank you, Dr. Kasim. Dr. Nedelkovic, your comments?
I wouldn't really do. This would be a damage control abdomen. I agree with everybody else. I would maybe put some air in the NG tube and make sure there's nothing leaking to the duodenum. That trajectory was close to the duodenum, so I'll be worried about that. It looks so. Just make sure there's nothing leaking there. I would also make sure that the right ureter or kidney is not injured or away from the bullet trajectory. And I think I'll probably go to scan and or IR to make sure there is no issue that would make me come back to the OR with that maybe a blush in the liver parenchyma. That would be a return for bleeding in a few hours to the operating room. So I'll probably do that. It's a CT with IV contrast if there's any blush or pseudoaneurysm, for which I would maybe get IR before returning in 24 hours to the OR. Thank you.
Thank you, doctor. Okay, Dr. Collet, we go back to you.
I go to show what I do. In the liver, the injuries, I try to control by pushing the epiplon through the hole, and then the blood was controlled. There's no problem in this moment.
You would swallow that, right?
Yes. And then I put 2 pads around the liver, and then make the control. I close the exit wound because the problem, the herniation, may become. I put a tie through the behind the hole, and I make a vacuum pack. Here's I'm making the vacuum pack. I put some plastic, put the dressing, and the pads, and then put the vacuum. Here's the end of the surgery. You can see the patient is still normal because I'm only tachycardic at this moment, but put the pads, and then, okay, here you can see the arterial blood at the end of the surgery, 40 hours of the surgery. The patients go to ICU, they recover. The mean pressure, blood pressure was 71. There is no vasoactive drug on the 48 hours. And so they decide for maybe reconstruction. They make enteroenteric anastomosis, may decide because it's near of the second, they make a partial colectomy and ileocolanastomosis. There is a difficulty to close the abdominal in this moment. So they put another vac in the situation, and the patient on the 6th post-operative day, the blood gas continues normal, the mean blood pressure is normal. Then they decide to close the abdominal wall. Here in our service, you make close the abdomen and put a smash, a pre-aporoneurotic smash only. That's usually we do this, and put a subhepatic drain. There is no injury for the pancreas. The pancreas is normal. There is no fistula from the pancreas, and there is no link of anywhere this patient. So in the postoperative, the 6 postoperative, you can see now the blood, white cells blood was increasing. And lymphocytes is normal, platelets is normal. So at the moment you make a CT. So it's very important that when you make damage or control surgery and put reconstruction and close and 3 times to reconstruction the wall, sometimes something may happen in the abdomen. So sometimes something may be problem. So you can see infection, and sometimes maybe collect and possibility of abscess in the abdomen. So can see the CT. Here can see the liver injury, can see on the CT now. Here and here, you can see there is, let me see more here. Oh, sorry. You can see here, can see a collection. I know here, you can see a subhepatic collection. Even the drain that was put is near the collection. So at the moment, the postoperative doctors decide to mobilization the drain. For me today, there is a problem here in São Paulo. They changed the program of the CT image. Here you can see the very easy to see the collection. And then drain is near the collection. Sometimes you think about what to do in this patient. So they ask you with these situations, what do you do with the patients? If you laparotomy, try to put a catheter through the endovascular or do radio intervention or something different.
Okay, Dr. Collet, we'll ask a couple of, because we're already almost in the hour, so I'm going to ask a couple of participants, okay? Dr. Kassim?
Okay. Dr. Kassim, what do you think is the situation?
So you have done an excellent job in getting the patient alive so far. So you have 2 collections with a white count of 20,000. And I think I would probably employ my interventional radiologist to see if there is a feasibility of draining these 2 areas with a percutaneous catheter. That's the first thing I would do before resorting to yet another laparotomy. And if I can get some samples from that, I would definitely send it for culture and sensitivity. Hopefully the patient is on some type of antibiotic, and I would readjust that according to the culture report. I think I would be a little more hesitant to go into the operating room now till I have had a good conversation with my interventional radiologist. Thank you.
Thank you, Dr. Kassim. Dr. Fraga?
I agree. I think you can go to radiologists, interventional radiologists, and try to put a catheter in this abscess, probably abscess, a collection. I was discussing with the residents here, sometimes when you put the epiplon in a liver tract, it's not so infrequent to have an infection, abscess. Usually here, you prefer to use the balloon, the liver balloon. You like the Saint-Stark Blackmore, but the trajectory is small, maybe 4 or 5 centimeters, Collet, the trajectory of the bullet in the liver. But at this point, I think you can try to then guided by ultrasound. I think it's all CT to put a catheter in the abscess in the collection.
Thank you, Dr. Fraga. Dr. Parreira, I saw that you raised your hand. Would you like to make any comment?
I'd say exactly Dr. Fraga just said. I would ask Dr. Collet, why not the transhepatic balloon they described in your Hospital das Clínicas? You taught us all this, so why wouldn't you use it?
Here, I want to answer you because it's very important. You can put a balloon, but the trajectory of the balloon may be the diameter of the balloon. The trajectory in this liver is a section, partial section of the liver on the segment 5. So there is a hole that more than 5 centimeters of the hole through this. So it's very impossible to put some balloon. So it's not easy to put some state Blackmore, the esophageal balloon through this hole. So there's no science to put it. You can put the sun balloon through the liver when you have a trajectory is a rectilinear trajectory, and then you can catheterize the balloon through them. So it's there you can put the balloon through them. It's very large. So it's not possible. When you put a the is very nice option to put sometimes to fix some injuries of the liver, because you can put the people through the hole, and they make big problem close the hole. So it's very easy to put, and the infections through using the people is possible, but it's not common. So we can use the balloon, the people to fix sometimes when you open the hepatotomy, you can put the people between the two sutures, and then very nice because sometimes avoid biliary link. So I think the epiplon is a very nice option when you have some big injuries. You can try to control. It can be avoid some links from the liver. So this situation is very important. And nobody asked me because why I do the cholecystectomy in this patient. I make the cholecystectomy because the liver injuries is near the gallbladder bed on the liver. So if you can wait, maybe necrosis of the ball, and then you have a link for this ball. So in these situations where we have, sometimes I prefer to take off the gallbladder and then maybe control the hemorrhage in this situation. But I think it's very important that in this situation, we can not put the sun-state Blackmore in this case. If you have a small injuries or more long injuries and small hole, you can try to put a balloon.
Okay, Dr. Collet, we go back to you. Yes, doctor.
Okay, let's go. I go to show what's happened with the patient, because I agree of the comments, because in this situation you can use radio intervention to make drainage of this collection. It was made, but they want to put to make this in the radio intervention. We have tried to push the drain, and the pus come through the drain, and then you can, when you go to see, don't see the collection more. And here is the one that they try to make this, and the mobilization of the drain. The patients become improve the parameters, infections, no link, and observe some adhesions here. You can see that I have on this next Friday. Can see the adhesions of abdominal wound. Can see the mesh, and the patient is normal. There is no problem, and we put in the abdominal hole a vacuum dressing in this situation to close the hole. So that's the case that I showed to present it. Is a very interesting case, I think, because you have a damage control surgery, you can go some penetration injuries, and then what complications may be possible with damage control surgery.
Dr. Lenin, your final comments?
Yeah, it was a great presentation. I mean, it's, you expect things where these complications after a case like this. I think everything was handled pretty well. We generally would, I think, would put a new drain in there. If you can get the old one to drain, that's fine. Yeah, but it was a great case.
Thank you, Dr. Lenin. Dr. Anchak?
Yes, I agree. Terrific case and superb judgments and a little bit of infection at the end. And I think you said you just tweaked the drain and then it functioned, which is a good thing to do. And if that didn't work, I think the interventional radiology would have been the next step. But extremely well done. If cases that were managed more aggressively before damage control became the vogue, if you proceeded to do a full reconstruction and the patient didn't survive, then you'd be open to criticism. I think there was Dr. Schwartz presented a case from Israel where he was cajoled into doing the reconstruction too early, and that's what happened in his case. So I think it's really a very good example that you presented and very well done.
Thank you, Dr. Anchak. I'm sorry, Dr. Ochman, your comments?
I think that this patient who came with was essentially a lethal injury, survived, and his only problem was a tiny abscess, is kind of clear evidence of the mastery of surgery that Dr. Collet had. I wish my patient would have that tiny abscess as a complication. I would probably call IR, but I have to say that manipulating the drain, if it works, is great. I really like your option of using the omentum to plug the hole, because it's vascularized and the surrounded areas around the hole is not, so that you bring healthy tissue inside the liver. And I think that decreases your risk of infection rather than worsening. So I think it was nice seeing that, how it looks on the CT, and I probably will do something like that if I have a situation like this in the future. So thank you very much. Regarding the Sextike Blackmore, it's a very good method to use Sextike Blackmore. Having said that, I think we might have difficulty finding a Sextike Blackmore tube in the Taft now. I know that we have one in the ICU, but one thing that Dr. Fried is not here. He used to be the most politically incorrect. I think now that comes to me, but this is true. Another way that you can fix that, because I came from very poor background, and it has been published, it's not something that I invented, is to use an NG tube, and this might help people who are in a very austere environment where the Sextake Blackmore cannot be found, is to use an NG tube and a condom. And you tie the condom, base of the condom with a tie at the base of the holes, the NG tube, and you inflate the condom with saline. It has to be saline, not air. And that's another useful way of tamponading and liver injury. I remember saying this in a conference one, and people thought it was crazy. Here there are too many crazy people, so probably I will get away with that. Thank you.
Thank you, Dr. Ochman. Dr. Kasim, your comments?
Dr. Hoffman, I'm not crazy because I have deployed the condom technique a couple of times in my surgical career, and it seemed to have worked. And I think Dr. Collet yet again has shown us what master surgeon he is. He alone can get away without big complication after a terrible case like this, and get away with a small little abscess that can be easily managed with drainage. I think it is a very good educational case for residents and other surgeons who do not have the kind of expertise Dr. Collet has, and the way he conducts is like a conductor in an orchestra. He does it so methodically, and It is really a joy to watch his cases being presented, and moreover, his visuals are so interesting and so clear. You get to see exactly what the master surgeon had done. Thank you for so much for educating us today.
Thank you, Dr. Kasim. Dr. Nedelkovic?
Dr. Collet, great case. Thank you for presenting it. I'm definitely gonna use that trick with the momentum. But one question I have is, what was that mesh that you used for closure? Was it Vicryl, or what kind of mesh did you use? Thank you.
The mesh is polypropylene. We in our service we use polypropylene mesh and fix it with the mesh with Vicryl, not fixed with polypropylene. So the result is usually very good.
Thank you, Dr. Collet. Dr. Fraga, your final comments?
Congratulations, Dr. Collet, another excellent case you presented. Congratulations for the video, the quality is excellent. I think everybody learned with this case, very interesting, the case. Maybe here you don't use the people in liver injuries, like this one is not so, the trajectory of in the liver is not so long, so maybe you can try to control only if the pads and control this bleeding. And usually you don't use the mesh during the to solve the problem of the abdominal wall. Maybe you try to close, or maybe keep negative pressure again, the baker, and try to the definitive treatment for the abdominal wall later. But excellent case, I learned a lot. Thank you, Collet, for sharing with us.
Thank you, Dr. Fraga. Dr. Martos, do you have any comments before?
Oh, can I just end the meeting?
Yes.
So again, another great case from Dr. Collet. As you can see, this kind of case can be managed different ways in different places, different countries. But at the end, you all want to go fast and treat the patient, stop the bleeding. So there's a couple good messages here about damage control, what to do, stop the bleeding, how to go fast to the OR, etc. Just remember, everybody, if you want to ask for CME, you have CME available for this meeting. If you just here from South America, just want a certificate, you can go through the link also and ask for a certificate. Please contact Valeria to schedule your case for the next weeks and months. And looking forward to see you all next week. If you miss this meeting or you want to tell anybody to watch the meeting, it's going to be available on the Pan American Society website and platform soon. Thank you all.